Good evening all. Today the video is regarding flow cross match, the part 2 video of renal transplant immunology series. One of my first year DM resident called me and he told he has difficulty in interpreting the reports and he doesn't know what to do once the reports are coming positive, and it totally confusing in the renal transplant immunology series is the Luminex or the single antigen beat assays. So after the previous video, that CDC part 1 of this renal transplant immunology series, he told he could able to understand the CDC report interpretation. So as per his request, I uploading the second part, the flow cross match. Before going into the video, this is a continuation of the previous video only. So whoever didn't see the last video, see that CDC video and come to this so that you will better understand this. So the concept goes like this, just a summary of the introductory part. Donor donating the kidney to the recipient. So what can occur? The recipient can reject the kidney because of blood group mismatch or HLA antigen mismatch. Blood group mismatch, as I told, we will see in a separate video. This series we are seeing the HLA antigen mismatch. So our role is to detect the HLA antigen mismatch so that we can avoid the hyperacute rejections. Hyperacute rejection occurs because of the preformed antibody in the recipient against the donor HLA. This and all I have explained in the previous video only. Class 1 HLA is present in all nucleated cells. Class 2 especially in the antigen presenting cells. So whenever there is an antibody in the recipient, the donor kidney can be destroyed. Since we can't check the donor kidney, we are taking the donor blood cells. The blood cell is T cell and B cell. T cell has class 1, B cell have class 1 and 2. So this we have seen, CDC we have seen. We have seen what are the positive test indication, interpretation, how the report is being given. Now we are going into the second room, which is flow cross match. What is the role of this flow cross match? This is somewhat more sensitive, or we are giving a two protection since we are going to do a major tissue transplant from the donor to the recipient. We want to be double sure that no antibody in the recipient is there to attack the kidney. So second test is flow cross match. This is how the report is being given. If you see, just a minute. See, the patient basic details will be given over here. The donor basic details, age, sample collection time will be given over here. So in the first line, you can see T and B cell flow cytometric cross match report. The parameters are given this side, remark is given this side. First is auto B flow cross match, auto T flow cross match, B cell flow cross match, T cell flow cross match. Overall, it is given as negative. So we will see what this indicates. As I told, donor donating the kidney. So the representational cells we are taking is the lymphocytes. T cell and B cell we are taking. Where the antibody is present? The antibody is present in the recipient. So we are taking the recipient serum and the donor lymphocyte. So we are going to mix both of them. If the donor lymphocytes and the recipient, if the patient is having antibody, if they interact, they will have fusion reaction or they will attach to the donor lymphocytes, and we can easily detect it by applying colorful antibody to detect this IgG. As I told in the first video, for transplant rejections, IgG is the most important antibody. So we are going to use a colorful fluorescent antibody which will go and attach to the IgG if there is a reaction. So better depicted here. So we are taking the recipient serum which might contain antibody, donor lymphocyte. You combine these two and on top of it you put fluorescent labeled antibody against IgG. If the reaction is between these two, this antibody will go and attach. There will be a colorful reaction which can be given as positive. If there is no interaction between these two, the colorful antibody, there is a fluorescent labeled antibodies won't attach there and the results will be negative. See, we have put the serum and the donor lymphocytes together. There is no donor specific antibody. So the result will come negative cross match because there is no binding of fluorescent labeled antibody. For example, if there are antibodies against HLA that will bind with the recipient lymphocytes, now if we add fluorescent labeled antibody, this will react. So we can detect this as a fluorescent labeled antibody by changing the color or by some interpretation. We can detect it as positive. So this can be positive, this can be negative. Nothing but we are detecting the HLA antibody. But what is the advantage? We already did it in the CDC. CDC is complement dependent cytotoxicity testing. But that will detect only the antibody which can activate the complement. But what here we are getting is it can detect the antibody which might not be complement activating. So this concept is very important. T cell contains class 1, B cell contains class 1 because class 1 is present in all the nucleated cells. Since it is an antigen presenting cell also, there will be class 2 antibodies. So advantages of the flow cross match over CDC. What are the advantages? Probably one more extra level of checking. It is better even detect a low level of antibody. It can detect only IgG because we are attaching a colorful antibody to bind to IgG. So whatever the class you want to, since for transplant we want only IgG. So specifically I can detect IgG. It can detect non-complement binding antibody also. Many a times there are two antigen antibody reaction. Some antigen antibody can activate complement and cause more destruction. Some antigen antibody reaction does not activate complement but still can cause rejection. That can be detected with the flow cross match. And what is the subtype of IgG can be detected because we are attaching some colorful antibody. If we make a colorful antibody against IgG1, we can make against IgG2, we can make against IgG3. Whatever the subtypes you want, you can make. So those and all will be a in-depth discussion of flow cytometry. Since I'm not going into the in-depth discussion, it is just one more advantage. We can select or detect a particular type of IgG. What is the type of antibody that can be detected? IgG1, G2, G3 or G4. So these are all the important advantage. So what if it is negative? For example, flow cross match is negative. That means good. There is no HLA antibody. You can proceed with the transplant. So CDC we have did, that is also negative. Flow cross match we have did, that is also negative. That means we are double sure. So the donor and the recipient can happily proceed with the transplant. Very less chances of rejection. Make sure there is a one more testing, Luminex, that I will discuss, but at least at this point of time you can be sure there is a green signal from the flow cytometry to proceed for the transplant. Well and good. But, so CDC and flow cross match are like adjuvanting each other. This is detecting complement mediated antibody. It is detecting non-complement mediated antibody. Double check, supporting each other. Just like the pic shown there, they are just adjuvant. But without flow cross match also, does transplant can proceed? Yes, we can proceed with the transplant, but we are double checking. That will be very clear once you see this concept. In cadaver transplant, where there is a patient who died, he want to donate the organ to someone. So after the accident, the organ will be retrieved, the donors will be called. It have to be given to the donor. Since we don't have time for flow cross match, we will be proceeding the transplant with the CDC cross match only. Does all the cadaver transplant goes for rejection? No. CDC itself is enough to proceed. But in a live transplant where we are having enough time, we are preparing, we are double sure, do the CDC, do the flow cross match. 2 times we are checking so that there is no HLA antibody. There is a green signal. Then you proceed to the next step or to the transplant. So flow cross match is not compulsory, but for a live transplant to be on the safer side, you have to do this. At least double check is required. CDC is the first check. The second check can be this one or the Luminex or the single antigen bead assays that I will discuss later. I hope till here you have understood flow cytometry in simple terms. Apart from this, some theoretical point, it was first detected in 1983. It was come into the clinical practice. The reports, as I discussed earlier, can be given as positive or negative, or if we want to quantify, since we are using the fluorescent labeled antibody, you can see the color. In simple terms, I am telling what is the color, how much bright fluorescent it is giving. In technical terms, or if you want to jump little bit detail into flow cytometry, it is called as channel shift. How much channel is being shifted. So this is what the channel shift is. This is where the juniors will get confused. What is channel shift? As of now, as of first year or second year DM resident, just try to understand the sequence of CDC, flow and Luminex. Once you understand this in simple terms, then you can jump into the details of this flow cytometry, the channel shift and all. The quantification can be done based on the serial dilution of the antibody, at what dilution the reaction is occurring. These are just for quantification, कितना react हो रहा है वो देखना के लिए. But in simple terms, you can just say as positive or negative. So that's all. So far we have seen the simple advantages of flow cytometry. If it is negative, well and good. But we will see a scenario. There is a donor, there is a recipient. CDC test is done, both T cell and B cell is negative. Okay. You are doing flow cross match. Flow cross match showed positive for T cell or B cell or for both. Then what to do? So first of all, you should understand why a flow cross match can be positive. First, there might be presence of low level HLA antibody which is not detected by CDC, but flow cross match have detected it. This is one reason. Second, the antibody which was detected by this flow cross match might be non-complement fixing antibody which is not detected by CDC. Does it cause rejection? Yes, it can cause. So this is another possibility. Third, it might be false positive, randomly positive aa gaya. Fourth, it is telling us there is an increased chance of rejection, search for the particular antibody. So we have to proceed with the further investigation. Probably single antigen bead or Luminex. The next step might be required. So these are all the 4 possible DDs. Whenever flow cross match is positive, again flow cross match T cell positivity increased indicates, because T cell have class 1, B cell have class 1 and 2. अगर T cell flow cross match positive indicates there's a high chance of rejection or false positive. B cell cross match, take it, you have to proceed to the next step or search for any of the cause. What is the cause? Whatever it may be, it's not a contraindication, but you, the nephrologist have to be aware there is an increased chance of rejection. So we have to heighten the immunosuppression. The rejection have to be reduced. At least you should know these 4 points whenever there is a flow cross match positive. And one more thing, when false positive can occur, whenever you give any treatment related to or the component containing immunoglobulin. For example, rituximab is the humanized immunoglobulin or IVIG, which we use for desensitization. Whenever we give this and you send the report the next day, you might get the flow cross match as positive. It is very common. Probably a DM resident seeing this video, you might encounter this. Your senior will tell not to send the flow cross match after giving rituximab or IVIG. They will tell you to send the flow cross match before giving rituximab or IVIG because it will give false positive results. So this can give false positive. And in the flow cross match, to avoid any technical errors, what they will do, they will take the recipient lymphocyte and auto react with the recipient serum to detect any technical error. They will check is आपको तो positive तो नहीं दे रहे, to check it is not giving positive to all the samples. For that, they will mix it with the patient's serum with the patient lymphocyte only. Same patient ka serum, same patient ka lymphocyte. That is what auto matches. Just a minute. So this is regarding the false positive reports. So whenever the flow cross match is positive, should you stop transplant? No. I have told you, probably I have told you the details. What are the possibilities you have to think of? It indicates the patient is at heightened risk. When CDC is positive, flow cross match is positive, better to stop the transplant. Take another donor. And I will discuss in that Luminex report interpretation also how to reject the donor or when to reject. So only CDC is negative, flow cross match is positive. The patient is at increased risk of rejection. We have to search for the particular antibody and we have to proceed with the more precious test, that is single antigen bead or the Luminex assay. So now we will come to the report again. This is the report from Lalpath lab. This is how the report appears, the name, age, lab number, collection date. This is of the patient, this is of the donor. So the report is given as T and B cell flow cross match, auto B flow cross match. That means they are taking the recipient blood, mixing it with recipient lymphocyte. So there won't be any technical error. They are doing it for T cell also. So these are negative. That means there is no technical error. They have kept a checkpoint with it by reacting it the recipient and the recipient. Now they are doing it with recipient and the donor with the B cell and the T cell. Both are negative. So that means flow cross match is overall negative. So what other detail is given? They have mentioned type of specimen is whole blood, some gating strategy, what they have used. This and all I will discuss in a separate video because this will take you to the depth of flow cross match. So as a beginner, you might not require all this. You understand the basics, then you go step by step, you will easily understand. So what is the thing they have mentioned? Note, tests performed on serum and whole blood. The flow cross match can independently evaluate T and B cell activity in mixed cell population. So what is the impression they have given? Flow cytometric cross match shows negative reaction with the donor T and B lymphocyte. Result might be considered in conjugation with other laboratory testing. This is what they have given an impression. And a few comment. Now you will understand the comment after seeing the discussion. Now you go through this. Just a minute. Now you can go through this. The test detects both complement and non-complement binding anti-HLA class 1 and class 2, especially detects IgG antibody. It doesn't matter whether it is complement fixing or not. It detects IgG antibodies. A positive flow cross match suggests increased risk of allograft rejection, but is not considered a contraindication for transplantation. The things I explained. Patient undergoing antibody modulation by means of IVIG therapy or and having recent treatment by antibody-based immunosuppression, for example, rituximab, may present with a false positive result. So they themselves is bringing this point. So the patient should not receive IVIG or rituximab before the sending this report. Why I am telling this? Because these are all the two drugs we might use for reducing the chances of rejection before the transplant. So if you give IVIG, do the test, it might come as positive. So what next? If it is positive, we have to proceed with the next one, Luminex or the virtual cross match. We have seen CDC, we have seen flow cross match. Whether it have to be done in all the patients or not, yes, CDC is compulsory. And regarding the guideline between flow cross match and the next gate, the next room to understand Luminex or the virtual cross match, we'll see in the next video. I hope you have understood flow cross match. Bye bye.